Well, thanks so much for joining me today to kick off Season 4 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. I am particularly excited today to be launching our new partnership with Scan Health Plan, a not-for-profit Medicare plan whose primary mission is to keep older adults healthy and living independently at home. As you may recall from last week's episode, I will be joining the Scan team this month as the inaugural CEO of a new medical group focused on caring for homeless populations using a street medicine model, and this is certainly something we will dive into more during this season. But with this new partnership with Scan, we are going to keep the Healthy Skeptic MD focus on engaging listeners in their own healthcare. And we're also going to add a new focus on some topics of particular importance to Scan, including older adults' health and also homeless healthcare. So I am truly honored today to launch this new partnership with Scan Health Plan with a guest that I admire greatly, someone who's been a very important mentor to me throughout my career, and that is Dr. Dr Mosqueda, a professor of family medicine and a geriatrician at the Keck School of Medicine of USC. Laura just completed a 3-year stint as the dean of the Keck School of Medicine of USC, and in fact was the first female dean that the school has ever had. She and I are going to talk today about the joys of taking care of older adults. Before we jump into today's discussion, as always, let's do a quick rundown of the health news of the week, starting with the pandemic news. So here in the United States, things are looking really, really good. Infection rates are very low. Death rates are very, very low. We now have almost half of the population fully vaccinated, and that's not even taking into account those who have natural immunity from prior infections. But sadly, things look very different in other parts of the world where the vaccination rates are much, much lower. So in a very important op-ed this week in the New York Times by Dr. Zeynep Tufekci, she argues that there is a very simple but not easy solution to the problem, and that is to redistribute vaccines from countries that are doing very well with the pandemic, like the U.S., to other countries that quite frankly need the vaccines more than we do. And she also argues that it's going to be very important to prioritize those vaccines to those at highest risk for complications in other countries. This is not an easy decision. There are many political, financial, legal considerations and so forth, but this is really an opportunity for the United States to show its character here and do what I really think is the right thing. I really hope we will strongly consider as a nation redistributing and being generous with our vaccines and to other countries that need them more than we do right now. So the second noteworthy pandemic-related news item is a new study in JAMA Internal Medicine this week looking at rates of reinfection with COVID-19. So in the analysis, they followed 1,600 patients in Italy who had previously been infected with the virus, and they found that after an average of 7.5 months and up to a full year, there were only 5 cases of reinfections with the virus, and only 1 person was sick enough to require hospitalization. So these numbers are very good, and they are at least as good as what we've seen with the immunity that's induced by the vaccine. So the final news item I want to touch on is firearms regulations. So as we all know, there is a frequent back and forth between gun rights advocates and those lobbying for stricter gun laws, but what's often missing from these discussions is actual evidence. And there was a really nice analysis a few weeks ago in the New England Journal of Medicine looking at regulations in Australia and the impact that these changes have had. So in 1996, after a mass shooting that killed 35 people in that country, the government implemented several new stricter gun regulations. So first, all firearms in the country had to be registered, so the government actually knew the guns that were out there and that its residents had. Secondly, all gun owners had to be licensed and screened for mental health and other concerning conditions. And third, there was a mandatory buyback program in which the government purchased back illicit firearms, including automatic rifles and shotguns from those who did own them. Now, in comparing the 17-year period before these regulations went into effect versus the 17-year period afterwards, there was a very significant reduction in firearms-related deaths from 3.6 per 100,000 down to 1.2 per 100,000, so greater than a 50% reduction. Now, the authors do acknowledge that this does not prove that the regulations were effective, but when taken into account the fact that firearms-related deaths increased during the same time period in many other parts of the world, it certainly is very encouraging. And I'm also going to make a quick note of some older data by Art Kellerman, which found that homes with firearms in them, the odds of a homicide in that household is 2.7 times higher, and the suicide rate is 4.8 times higher than it is in households that do not have firearms in them. So I know that this is, again, a very tricky policy topic, but I do hope those making the decisions will at least take into account some of these statistics. So that's it for the news summary. Now we're going to jump into our interview today with Dr. Laura Mosqueda. And I will just mention that if you do enjoy what you hear today, please do search and subscribe to the Healthy Skeptic MD wherever it is you listen to podcasts. Please search on YouTube for my YouTube channel, and please pass it on to friends, family, and others who might be interested. And if you do have a chance, please consider leaving a review. Well, I'm truly honored today to be joined in the Healthy Skeptic MD by Dr. Laura Mosqueda, Professor of Family Medicine and Geriatrics at the Keck School of Medicine of USC.
Well, it's a pleasure to be here. I'm a big fan of the show, so it's a treat for me.
You know, I've been looking forward to having you on at the right time because you have so many great insights on the themes that we do in this show. So I wanted to start at the top. You have told me previously that you became a geriatrician because you really like working with older people, dating back to your grandparents. Tell us a little bit about that.
Yeah, I don't know what it is, but ever since I was a little kid, my parents told me I had gravitated toward older adults, and I did have wonderful grandparents that I grew up with, so I'm sure that was a great influence on me as well. But I've just always had a real connection with older adults and continue to.
Yeah, well, I'm not a geriatrician, but I always say they are my favorite patients because they have a different perspective on the world than the rest of us that we all probably could learn from. And is that something that you found as well?
Yeah, truly. I think, for me, one of the really fun things about geriatrics is just the combination of things. It's really like intellectually satisfying because it's, an older adult comes in with something like fatigue, and it could be anything from something going on with their hearts to their lungs to their brains. It could be depression, it could be a heart attack, it could be a endocrine problem like thyroid disease. So it's really intellectually interesting. And then the other thing that's fun is you get to work in teams, which I love. So work a lot with social workers and nurses and physical therapists, occupational therapists, speech language pathologists. And so the teamwork is really fun. And then there's the people themselves. What a joy. I mean, how special is it to have a conversation with somebody who's 90 or 100 years old and hear about their lives and what they've experienced. It's magical.
It's a really interesting point about how intellectually interesting it is. I think a lot of times you think, maybe there's less to do with geriatric patients, but there's so much nuance in balancing what evidence-based treatments you can use that aligns with their goals of care that I actually think it's the most intellectually interesting population that I work with.
Well, of course, I'm biased, but I would agree. I mean, you bring up another really important point, which is evidence-based. It's harder to do evidence-based medicine in geriatrics because so many studies have excluded older adults. That lots of times we're taking what we can from an evidence-based approach and extrapolating it to the best we can. The best we can with older adults. And the other important point you just brought up is making sure it aligns with their goals and their values. That might be something we want to talk a little bit more about.
Yeah, we're definitely gonna get into that, but it's a really important point that a lot of the research has not been done in geriatric populations, so there is a little bit more of extrapolation and judgment with geriatric medicine than in other areas. And I also love what you said just about, the experiences of 90-year-olds. Sometimes we all get caught up on silly things. And I always feel that after talking to an older adult, I just have a better perspective on life about what really, really is important.
Yep.
So the other thing I wanted to ask you about before we get into some of the substance here is I read Atul Gawande's book, Being Mortal, that many people, it was a New York Times bestseller a couple years ago, and it really influenced me. It talks about how other cultures deal with aging much differently, and in particular, there's a lot more intergenerational households. which deals with the issue of older care because of people who are living with their younger family members, but it also just the interplay, the constant daily interaction between younger and older generations just seems so good for society. And it made me feel that we're missing out on a bit of that here in the U.S. Is that true?
I think it is true. It's so interesting. When I give a talk to first-year medical students, I'll ask for a show of hands. How many people were raised with grandparents close by? And a lot weren't. So, we not only live in separate households, but often across the country or in different countries. That's become much more common. So there's a lot less interaction that goes on from younger ages with grandparents. If you get a room full of geriatricians together, certainly people are talking about their kids, but we're also talking about parents and grandparents as well. And so you can see the influence that growing up with older adult role models has. And I think one thing we might talk about later is the need for more intergenerational activities to sort of make up for that in our country and really in the world.
Well, I definitely want to come back to those issues, but the next topic I want to ask you about is you've also told a story about being a geriatric trainee and encountering an older adult who sadly had been experiencing abuse. Could you tell us a little bit about that and how it influenced you?
Sure. Well, this is when I was a fellow, and it's a good lesson in a few ways. One, just the impact of that one single patient or issue can have on us earlier in our careers and what it means for the rest of our career. This was an older woman who came in to see me when I was a geriatric fellow who had a large welt on her arm. And just to show you how old I am, this was a time when we had these things called telephones.
The most underutilized healthcare technology, in my opinion.
Correct. And I said, what happened? How did that happen? It was in just an unusual spot on her forearm. And she said, well, my daughter hit me with a telephone receiver. And we talked about it, and it turned out that this actually was a fairly regular occurrence. Long story short, I called Adult Protective Services. A lot of people have heard of Child Protective Services, so this is kind of the corollary on the other end of the age spectrum. And I was very surprised when a few weeks later I saw this person, and I asked her what happened, and basically nothing had happened. So I self-righteously, as you do when you're younger, marched into Adult Protective Services to say, hey, what's going on? How come we haven't looked into this? And what I really learned is how big a problem the medical system is, and how big a problem it is that these APS workers are out there, for the most part social workers, trying to do their best, but with very little or no medical backup. And that sort of really started me on an academic career focused on elder abuse.
So we hear a lot about the issue of child abuse appropriately, but less, I think, about elder abuse. How common is the problem?
It's pretty darn common. It's estimated that about 1 in 10 older adults gets abused or neglected at some point. But what's really shocking is if you look at people who have Alzheimer's disease or other types of dementing illnesses, they're about 1 in 2 will get abused or neglected at some point during the course of their illness. So this is pretty common.
And I'm sure it runs the full spectrum from just neglect to outright abuse. At the risk of asking too blunt of a question, what are some of the types specifically of abuse that adults experience?
Unfortunately, there's lots of different ways to abuse an older adult. There's financial abuse, there's emotional abuse, and then we also have physical abuse, sexual abuse, neglect. So there's quite a variety of ways to harm an older adult. And the other piece of this is it's not just a range in the types of abuse, it's actually pretty common for there to be more than one type of abuse going on, that we call that polyvictimization. The other thing is there's also a range in the severity. And that makes one of the things, makes it a little more difficult to also study it and understand it, because when does, there's some people who we call the Bickersons, and their lifelong marriage they've always kind of gone at each other. But now one has developed Alzheimer's disease and maybe can't defend himself as well anymore. And she still goes at him, but he doesn't quite understand it. So now you have a lifelong pattern that kind of worked for them in their own interesting way. But now it actually becomes abusive. So we always talk about it crossing the line, but the problem is there is no line. there's just a big wide boundary.
Yeah, well, I'll say that subtlety is something that I experience, that I, as you said, see two older adults bickering who are married, and, when is it abuse and when is it just their personalities. Similarly, sometimes I'll go into a nursing home and I'll see a patient who looks dehydrated and some of their electrolytes suggest that they are not being adequately cared for. But on the other hand, those electrolyte abnormalities are just things that happen as people get demented. In some cases, it's just really subtle to know what's abuse and what's just the disease taking its course.
Yeah, absolutely right. And this also led to some of the work I've done on what's called forensic markers of abuse. I went on a lot of rides when I was working in Orange County with adult protective service workers, and ended up on ride-alongs with police as well, just to understand what it was they were seeing. I would sometimes see older adults who are massively bruised and say, hey, we got to pay attention to this. Something's wrong here. And I would always hear, well, they're old people bruise easily. There's nothing we can do about it. You can't prove it. So we actually did some of the landmark studies that say, well, this is what bruising looks like in older adults who are not abused, and it looks different in people who are abused. One of the really interesting issues in older adults who are being physically abused and neglected is you can almost always find a reason other than abuse, that somebody has a bruise, a pressure sore, a fracture. And so it, I think, makes us sometimes too timid to say, that really shouldn't be happening. We got to look into this a little bit more, and not just accept that they fell. Why did they fall? Maybe somebody pushed them, for example.
Yeah, the other tricky one is pressure ulcers, right? Because on one extreme, that can be the sign of neglect. On the other hand, people who are sick and older do get pressure ulcers no matter what you can do. And, there's been a big push to hold nursing home administrators accountable. Some have even gone to prison, probably appropriately in many cases. But I've also seen good nurses who really are trying their best, and pressure ulcers develop regardless. How do you tell a pressure ulcer that's from neglect versus just a regular medical ulcer?
So this will not be a data-driven answer, but it'll be based on quite a bit of experience with this. I do not believe that pressure sores are always a sign of neglect, but they can be a sign of neglect. So we have to always look at it. So for me, what's really important is the context. I've seen pressure sores that are very deep, that are in awful condition. They're infected. They have awful smells. They haven't, clearly nobody's recognized it, cared for it, or somebody says, well, it just came up yesterday, and you have to kind of say that didn't happen in 24 hours. Right.
Yeah.
And so I think if we as a medical community just paid attention to the really blatant, obvious ones to start with, we would be light years ahead of where we are right now, instead of just saying, well, they're old and they're immobile, and so this is what happens. I was just on a house call, 2 weeks ago, related to our Elder Abuse Forensic Center, and I saw a man who was just almost always lying in this recliner chair in the living room in a very chaotic household, in a diaper, lying in feces, lying in urine, who had pressure sores on his buttocks. That was neglect. That was not just, gee, stuff happens. Nobody was changing him. Nobody was helping him. He was completely incapable of doing this on his own. People were living in his house, family members, because it's his house, so they needed a place to live. And they also, I think, were benefiting from the Social Security checks that were arriving in the mailbox.
Yeah, I think that's a really important point, that there's some obvious cases where there's no subtlety involved. And if we just acted on those cases, we would be a long way ahead. Many of my listeners are lay audience members who maybe have family members in nursing facilities or living alone or with a spouse. If you're a lay individual, when should you sound the alarm bells if you see a bruise or an ulcer on your loved one, or is that where you get a medical expert to advise you?
Yeah, I would really ask questions, and it doesn't have to be that we raise an alarm. I think sometimes we feel like, well, we don't want people to think we're accusing them, and well, you don't have to go and accuse somebody. You can just say, hey, Grandma has a bruise in a really weird place. What happened here? I will tell you, particularly in nursing homes where I've worked, but I'm also a volunteer long-term care ombudsman. So I go into nursing homes as a volunteer just to check on people and as part of this volunteer program. And you can see how stressful it is for the people living there, for the nursing assistants who get terrible wages in general, of trying to deal with this, working long hours. But still, people should be getting good care. And I do think that administrators should be held accountable. There is a huge issue related to for-profit nursing homes, and I think there have to be policy changes that occur in order to make these places more livable. I can't tell you how many older adults I've seen in their homes who were being neglected, who were being abused, who said, I'd rather stay here than go into a nursing home. So we need better alternatives for older adults, but that sort of gets more into the policy arena. I think that that if you see bruises, pressure sores, asking questions, it's all about the context. So if I, as a clinician, am seeing somebody who has a pressure sore, I want to know, whoever's supposed to be caring for them, were they aware of it? Have they been getting appropriate treatment, or at least looking into it? If the answer to all those things are no, and it looks a mess, I'm going to be a lot more concerned. When in doubt, you make a report. When in doubt, have it checked. This is your loved one. So, we want to be careful that we're not going around and accusing people all the time. But I think we've become so worried about that we're also not kind of calling it when we know something bad is happening.
I think that's a really good advice, to ask questions. If you have a loved one, and just asking questions of concern with an open mind that this may actually be good care, but these bruises happen sometimes. But that's how you sort of get to the bottom of it, whether people are really doing their best to address it, or there's a deeper problem.
Yeah, and put your common sense hat on. You don't have to be a trained professional for this. So if you have a loved one who has kind of weird bruising, and you just ask a question, hey, how did this happen? I saw these, and they give you a story that just doesn't fit or make sense. People shouldn't be ending up with wounds on the bottom of their feet, for example. How do those things happen? Or bruising on their inner thigh. I'm going to want to hear some story that makes sense about how that could possibly have happened. Or somebody who, quote, fell, but they're unable to walk or get out of bed on their own. So just, listen respectfully and carefully to what people are saying. And then see if it makes sense to you, and use your good judgment.
Yeah, one scenario that I've observed, my own personal experience, is sometimes with the feeding issues with patients at the end of life with dementia, they do experience dehydration, and they're not taking food or drinks orally, and giving them IV fluids is not good for its own set of reasons, and putting a tube feed is not a good set of reasons, and family members are concerned that that's a sign of abuse at the nursing facility. So I've sometimes been doing sort of that delicate dance by saying, absolutely, we want to take these issues seriously, but putting a tube feed in or an IV is not necessarily the answer here.
Yeah, it's almost never the answer, because it gets back to what you talked about earlier, which is, what are the goals of care? And so when you're kind of moving toward an end-of-life situation, the goal of care is making sure somebody is comfortable, peaceful, and so putting down a feeding tube or inserting an IV does not meet those goals of care. That's when it's appropriate to say, yes, your mom or your grandpa is going to gradually get dehydrated. It's a very peaceful way to go, and we help people go through that process. And so it isn't the actual bruise or the actual dehydration, or it's the context in which these things are occurring that we have to understand in order to figure out, is this the kindest way to go? Was this an appropriate thing to happen? Or this was an unfortunate thing to happen that happened despite good care? Or, hey, Houston, do we have a problem?
Well, I think that's a good way of putting it, and it's definitely a delicate balance. Now, I do want to shift a little bit to the policy issues that you started to mention. You're really an international expert in policy for elder abuse. And just at a high level, what policies would you like to see differently that would allow patients to be safer either in their home or nursing facilities?
Well, on kind of the grand scale, I think we need radical change to nursing homes. When we looked at what happened with COVID, I mean, what other group could you have put into solitary confinement without their permission for such an extended period of time other than those vulnerable older adults? I think that was an absolute horror for the older adults themselves, for their families. The tragic story after tragic story is just an absolute heartbreak. Absolutely, we needed to make changes and have some protections related to COVID. But after a short period of time, we knew enough about what was going on. And I feel that this is a vulnerable population. We live in an ageist society. All of that was taken advantage of, and this should never happen again. So what did this expose? I mean, what is it that COVID exposed that I think many of us were aware of already in nursing homes? Poor staffing. We know that staffing ratios are very important for good care, that they're not upheld. We know that training is important. We know that living wage is important. The people who work in nursing homes often get paid very little and have very little in the way of benefits. That's why they were having to go to so many different nursing homes. They're trying to make a living, and they ended up spreading COVID. And then just the whole for-profit nursing home industry. I think there's just a clear lack of transparency about what happens to those profits. They're tied up in real estate deals, and they're not necessarily there to serve the best interest of the older adults who are living there. They are nursing homes, and they're supposed to be homes where people live. They should have their own rooms. They should have visitors. They should have a lot more. And I know that a lot of people who live there have dementias and a lot of physical disability, but still, they're not pieces of furniture. They're human beings. There are loved ones with histories who deserve much more respect and dignified care than they currently receive. And this boils down to a lot of policy, whether it's payment, transparency, et cetera. I think the other big policy issue is we need better alternatives. Adult daycare programs, adult day healthcare programs, senior centers, that make it easier for older adults to live in our community, better transportation, housing, all of these things that are actually good for all of society will particularly benefit older adults as well. It's a little bit like when the American with Disabilities Act passed and we had curb cuts and bigger bathrooms and all that sort of stuff. It was theoretically for people with disabilities, but it helped everybody. And I think that anything we do to make our society as good as possible for the most vulnerable makes it as good as possible for all of us.
So I want to pick up in a moment on those alternatives, but first, at the risk of asking a political question, to your question about the for-profit nursing homes, should nursing homes be allowed to be for-profit, or is there a way to restructure it so that patients are protected?
Well, I would love to really engage the nursing home industry in that conversation to say, okay, if it makes sense for it to be for profit, let's figure out how to make it better. The government regulations have been weak and are weakly enforced. And so, if something really awful is happening in a nursing home and they have a $10,000 fine, that's just the cost of doing business, no big deal. So we need to have better regulations. We need to really enforce those regulations. And I think sometimes, criminal prosecution is entirely appropriate. But instead, that is not what is happening anywhere nearly to the extent that it should be. So I would say that if a for-profit industry makes sense, let's be open about it. Let's be transparent. And talk about how we do it in a way that makes sense. And if we can't figure that out, then I think we need to say, this isn't the right model. We need a whole new model for nursing homes.
Well, I think that's a really balanced perspective. And I guess the only insight that I would add is that even some not-for-profit nursing facilities have some of the same problems that for-profit ones. So I think regardless of the financial incentives, that's not the entire problem.
Yeah, you're right about that. I think financial incentives are a big part of it, and I do keep harping on it. But there's a whole host of other issues, and it can happen anywhere. You're right.
So in terms of like creative, innovative alternatives, You've done a lot of research in other countries, Israel and other parts of the world. What models have you seen out there that we should be doing more of here in the U.S.?
Yeah, I think there's a variety of things. Interestingly, in Norway, they have some nursing homes that are very similar to what we have, but they also have alternative models that are much more like real homes and in places where you'd want to live. Actually, in our own country, there's been a movement called the greenhouse movement related in nursing homes, and it's really interesting. I need to dig into this more. Like, why hasn't that spread? Like, these need to be economically viable and make sense. But we also have, even when it comes to regulations related to building codes that interfere with people's ability to really make these nursing homes into much more homey places. Also, because they're so medicalized, we have all the rules and regulations that lay over it related to medical care. And I think it needs to be more focused on the home part and less on the nursing part. I think the other interesting model are things called large communities that started in France that were really designed for people with disabilities that allow much more autonomy and empowerment of the people who live there, even though they might be impaired. But this is really about the people who live there. This is their home. And then the other folks who might be nursing or nurses or nursing assistants or doctors or administrators are there to serve them, not the other way around.
I think your point about over-medicalizing older adult care is true not just in this case. It's the theme of this podcast. Is too many times when we try to over-medicalize things, it leads to trouble. I completely agree with that idea of creating communities where people are living. They're not medical facilities like a nursing home, but they provide that baked-in medical care. One setting that I've worked in is a PACE program for all-inclusive care for the elderly, which is essentially an adult daycare facility that happens to have doctors and nurses and therapists built in. There's some financial challenges with that because it's an expensive model, but there's probably some intermediates that could work at a broad scale.
Yeah, I think the PACE program is fantastic, and you can see, it started in San Francisco, but it now has become a national model. And the payment piece of it and how you keep these things working because they're expensive is always interesting. And I have two thoughts about that expense piece. One is good care is expensive, and it doesn't bother me. I think we should say this is what it costs to do it right, and that's okay. That's what we need to spend. The other piece is, it saves money down the line, but the problem is the place where it saves the money is not the place that's getting paid, and so you just don't have all the risks and benefits in terms of the financial risks and benefits aligned and going in all the right directions, which is true all over the place in medical care. That makes it hard to do the right thing, at the right time.
Well, one of the big challenges is most Americans do not have long-term care insurance that would support them living in a facility like what you're describing, or I should say a community, I should probably better say, like what you described. And it's sad because right now our Social Security system is facing a lot of trouble. Medicare has financial challenges, but I actually think that's the answer, is to reinvest in a national long-term care insurance system, maybe through Social Security.
Yeah, and I think there's a variety of governmental agencies that can look at this. The governmental agency called ACL, which is the Community Association for Community Living, under Department of Health, under DHS and CMS, tried looking at this. And it got knocked down. This was under the Obama administration. And so I think it's time to look at this again. So there have been attempts to do this at a large level in the past, but so far we haven't been able to make it happen.
Well, I had a similar feeling to you did about why are these residential communities that do exactly what you're describing, why aren't they taking off? Why isn't the market making them spread. And I remember feeling that after the Atul Gawande book, which describes some of these examples. So I'm also a big advocate of some policy change that would create sort of the long-term care insurance structure that would allow this. And I think it would be maybe cost money up front, but in the long run, it would be pound smart.
Right. And I think that's part of the problem with policy, as far as I can tell right now, and with politics, which is it's now harder to really have that long-term thinking, 10, 15, 20 years down the line, what you have to invest in for that payoff, because people are worried about getting elected in 2 years and how things are going to look for these very short-term payoffs. I think the same is true when it comes to just businesses. It's that bottom line. It's driven by what your board of directors wants, or what kind of return on investment your shareholders want to see in a very short term sort of situation. I'm reading a really interesting book right now called Sapiens, and it makes you sort of step back and look at bigger picture. And 20 years is nothing. This book is looking at things over hundreds and thousands of years. But that's when you really see what happens with human behavior and human culture.
Yeah, that's a great book. I've read parts of it myself, and does put things in perspective for you. You mentioned what we've learned from the pandemic, and there were so many important policy decisions like visitor policies during COVID. There's obviously benefits in preventing spread by banning visitors, but that has really important impacts on social health, emotional health of residents of nursing home facilities. And I think for me, what it highlighted is how residents of those facilities were not empowered and engaged in those decision making. Do you agree with that, or what did you see?
Yeah, I do agree with it, and it is what I saw. I went into a lot of nursing homes during the height of the COVID epidemic, and it was just a heartbreak. And so people were not allowed to have the connections with the people who really love them, and in terms of family and friends being able to visit. And there's a certain amount of understanding about wanting to be really careful about spread of infection. So I sort of got it at the beginning. But as you said, the older adults were not consulted, families were not consulted. These were just rules that they were allowed to lay down because it made it easier for the nursing homes. We knew before COVID hit that there were severe problems with infection control in nursing homes. And this is another area where there are rules and regulations, but they don't get enforced. And it came knocking on our door because we saw places that just weren't ready for it. I certainly have witnessed it as a volunteer ombudsman going into nursing homes and seeing people who weren't masking up or putting on gloves appropriately, etc. And you remind them about it, but this is why things spread like wildfire. I think the other thing that happened in some places is they were getting more pay if they were accepting patients who were COVID positive from hospitals, because hospitals were desperate to move people who were COVID positive out, especially some of these older adults. And so some nursing homes have very much of a financial reward for doing this, and then didn't have proper infection control in place and ended up infecting people who otherwise would not have been exposed. That wasn't because family members were coming in.
That was the irony. That they had extremely strict policies about visitors who had important emotional and social benefits to the population, but then hospitalized patients who were still contagious were allowed to come in. No one tried to make that happen, but it was, as you said, the financial incentives that was the result.
Right. I mean, none of it was intentional harm, but that doesn't make it okay. And I think the isolation that older adults experience, and I think that a 98-year-old should be able to make a decision of, I'd rather take the risk of getting COVID and have my daughter visit. I think that's her decision to make, rather than being told what she can and can't do.
Yeah, that was my main takeaway, is that the older adults themselves should have been more involved in the decision making, rather than policymakers thousands of miles away calling the shots. One more topic I want to cover today, Laura. This has been really great so far. You do a lot of home visits throughout your career, including during the pandemic. What do you learn by getting into older adults' home spaces?
Well, seeing somebody in their own environment, I think, is a great way to get to know somebody. A lot of the people I'm doing the house calls on are people who are debilitated physically and or cognitively, and so it's really hard for them to get out. So what might seem like no big deal, just bring your mom in for a 20-minute appointment in the office. If this is a woman who has, say, vascular dementia or some other kind of dementing illness, might be a whole day of upset of trying to get her up and dressed and arguing to get her in the car and then out of the car. And so when you're hearing about that, then I think the right thing to do is a house call. And you learn so much more. You get to see how they interact with the dog and what it's like to get in and out of bed. You get to see what kind of medical equipment they have or might not need. I'm always asking if I can go into bathrooms to see, you're preventing falls, hopefully, by looking at fall risk. So you're getting a sense of the physical environment somebody's in. Is it a dangerous neighborhood? Well, that's why they're never getting out for a walk. They're scared. They're scared to go out. So you get a sense of the physical environment, and you get a sense of the emotional environment as well. And people, I think, very often are much more willing and able to open up and talk to you about what matters to them. And are often very grateful. The other, I think, important piece is then when it comes to end of life. For example, I was just seeing somebody last weekend at home, and she's on hospice now, and there's going to be a hospice doctor involved, but I'm still going to be there with them. The family knows you're going to be there with them, and there's just a sense of familiarity and comfort that you've been seeing them for a while at home, and now you're going to help them through the final stages along with hospice.
Well, in terms of that experience of going to a patient's home, I remember being a medical student doing a home visit, and I remember this older person was on maybe 6 or 7 different medications, and we got into their house, and there were about 20 different medications in different bottles, and it wasn't clear that the pills were even in the bottles that were labeled correctly. And what my takeaway from that one singular experience was just, how complicated it can be with the medications at home. And we need to be doing everything we can as doctors to keep it as simple as possible.
You're right. I learned a really good lesson from a nurse. One of the things that I really benefited from, particularly during all stages of my training, was getting training from a lot of different disciplines, PT, OT, nursing, etc. And there was a nurse who really taught me a lot about house calls, and she had this great technique. So she'd say, "Show me your medicines." And we would go into the kitchen where they keep their medicines, and she would say, "Where else do you keep your medicines?" And then we would go into the bed, and she would just keep saying, "Where else? Where else? Where else?" And it was amazing. I still use that technique, even though I learned it 30 years ago. And as you say, you learn all kinds of things.
Yes, the simple things that stick. During the pandemic, you've been giving vaccines to patients in their home. Is that correct?
Yeah, I think, we really saw a need for people who have trouble getting out or, just not going to be able to get on the internet and figure out how to get to Dodger Stadium or whatever they need to go to. So when the J&J vaccine came out, the Johnson & Johnson, and it was just one shot and you would be covered, we saw that as a really great opportunity to find older adults who couldn't get out and go and administer the vaccine at home.
Well, I'm sure the patients really appreciated that and their family members for not having to sit in line at Dodger Stadium to get the vaccine and make it more accessible.
Yeah, and people talked about how life-changing it was that they could have visitors now, and it was very touching.
Did you see anything unexpected in the homes that you visited from people who have maybe been inside over the last year more than typical?
Yeah, one thing I learned, one thing we did is we worked with a local senior center, or the Pasadena Senior Center, and had them help us identify people they were aware of who were so-called homebound or had trouble getting out. And you would go to some of these homes and they would want you to do everything on the porch because they were embarrassed about the condition of the inside of their home. And so I saw that actually quite a bit. I went into one place where they didn't even have a front door. It was just a curtain.
Well, the last question I have, Laura, is you have a really exciting new opportunity. You're going to be starting a geriatrics initiative at the Keck School of Medicine, and you've I know still thinking about it at what exactly the focus would be. So you may not have all the details yet, but we'd love to hear at a high level what you're thinking.
Good. I'm glad it's a high level because I have no details yet. Part of what I've learned, I think, during my history of various administrative roles is it's great for me to have ideas, and that's always fun for me. But what does the team think, and what is the system ready for? And what I'm trying to understand is, I think I have ideas about what a great geriatrics program could look like, and at the same time, I'm trying to understand what our own health system is ready for. So I'm working in a health system with a big focus on tertiary and quaternary care. So the question then is, what role does primary care geriatrics play, and how can a geriatrics program really help in a tertiary quaternary care environment? So this is what I'm trying to figure out, to see what we're ready for, what would be most helpful, not only to my patients, but to my colleagues.
Well, as you know better than anyone, we're facing a silver tsunami, an aging population, and there's going to be a tremendous need for well-trained clinicians in all disciplines in healthcare to take care of this workforce. I know you've done a lot in that area too, so I hope there's some workforce development in this initiative.
Yes, my colleague Bunny Olson is the lead on a big geriatric workforce project that we have going. She's a geropsychologist. The other thing I'll mention is this whole phrase of the silver tsunami. It does make me cringe just a little bit, because a tsunami is a destructive force. And I actually think that this aging population we have is a force for good, an untapped resource that brings me a lot of hope in terms of the wisdom and ideas that older adults can help us all live better lives. And so I don't see aging as a destructive force at all, but I think it's a very good force for our society if we kind of tone down the ageism and then tone up our ability to hear what it is that older adults have to offer in terms of wisdom.
Yeah, I think that's a great sentiment to end on. And I think you said it exactly right. There's so many exciting things about the fact that our demographics are shifting, and so many good things that could come from our society from this shift. Well, Laura, I want to thank you so much for joining me today and sharing your insights. You have such an interesting story about how you got interested in caring for older adults, and you've done so many good things throughout your career, and I know it's just going to continue with this new initiative you're doing at Keck School of Medicine.
It was a pleasure.
And if you do find today's episode engaging, please search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts, on YouTube. Leave a review if you have a chance, and please pass it along to friends and family. We'll pick it up again in 2 weeks. Thanks for joining.